Okay, let's do it.
Sorry. It's rhythmic.
Look at here.
Where...
We have 12 leads, and
oh.
when only 2 beats is presented, you should look at the rhythm strip. Okay, and here you can see the rhythm strip. That is a longer one. Okay, so please consider.
So it's a rhythmic.
1,
2, 3. Just 1 second.
I don't need to count it, but the rate is around 60 or so. Okay, so it's so good. All right.
The QRS axis is normal.
Okay.
It's more towards 60 or 60. And what else? The P waves are followed by P waves are followed by QRS waves.
Okay.
What else?
Everywhere.
No, not in the AVL.
In V1, if you do see, because that's a longer strip, these are the P waves, and the P's comes regularly. However, not every P followed by QRS. We have a dropped P. So it's meaning, what does it mean?
Premature atrial beat.
No. It cannot be an impulse formation abnormality because the sinus firing regularly. And 1 P not followed by QRS, so it has to be a conduction abnormality. What kind of conduction abnormalities? P not followed by QRS. So the connection between the atrium and the ventricle is abnormal. So
AV block.
Exactly. What type of AV block is?
Okay, so it would be second.
Yes, second degree AV block. And which type? How can you judge? How can you differentiate between the AV blocks?
Okay, I think so. I think second one is
the last one. This is the unconducted bit. Okay, so the last one, the PR, should be compared to the first conducted PR, and the last one is longer than the first one, so they are not equal. Meaning,
the first Mobitz type.
Mobitz type 1, Mobitz type 1. Okay, so that's a Mobitz type 1, second degree AV block. Okay, next one. Okay, the width of the QRS is narrow. Okay, there is no problem with it. And anywhere can you see pathological Q waves?
Pathological Q waves. No.
No. Okay, so there's no pathological Q waves. Another thing that you have to look at, hypertrophy, ventricular hypertrophy, but there's not too much or not too tall, V5, V6. Okay, so there is no left ventricle hypertrophy, nor right ventricle hypertrophy. So that meaning nothing else. That's it. Okay. All right. So that's it. Only we had a second degree AV block, Mobitz type 1. That's it, period. All right. Thank you. Next one, the next one goes to Amit or Amit.
Yeah, hi.
Okay. Your turn.
Okay, looks regular.
Okay. Yeah, no, that's regular. All right. Okay.
Let's say around 75 beats per minute,
Okay,
maybe.
good, very good. Go on.
P wave morphology is upright where it should and negative in AVR, so let's say it's sinus.
Okay, very good.
Axis lead 1 is equiphasic, so
Okay.
that means it's more towards the AVF.
Okay, so it's around 90. All right.
Yeah, what else?
Pathological Q wave
Yeah, we
inside the
can see in
QRS.
one AVL.
All right. One AVL, very good, but
And nothing
nothing
G5,
else.
G6, yeah.
Okay, and ST segment?
Is a bit, maybe I can call it, yes, so it's the elevation in one AVL.
No, it's not ST elevated because it has to be more than 1 millimeter, and this is not. So I don't think that is any ST elevation. Only what you have to see, I do see
Q
here,
wave inversion.
the
Yeah,
negative T, the
MI,
current T. Yes, but what kind of MI is this?
Lateral, yeah.
High lateral, and which phase?
It's few weeks old probably, so
No. Yes, that's a subacute, high lateral, and nothing else, no hypertrophy, and the normal width of the QRS. So that's it. Okay, nothing else. All right.
Professor?
Good. Yes.
Could you explain again why this is an MI? I don't think I understand, please.
Okay. All right. First of all, we do see Q waves, as you see here in lead number 1. All right. So the size is about the same as an R waves. This has to be a pathological one, and in lead number 1. And in a side by side with AVL, we do have another pathological Q wave. So in 2 waves that side by side showing the high lateral area, we do have pathological Q wave. That means we do have necrosis. All right. And necrosis is initiated by MI for sure. Next one, in this same leads, you should look at the ST segment, whether it's elevated or not, to see whether in time it's an acute if you do have Q and ST elevation, but there is no ST elevation because it should be more than 1 millimeter in the limb leads. However, you do see the T inversion. That can be a subacute. This is how you specified. If you do have only ST elevation, that meaning hyperacute. If you do have a Q wave and ST elevation, that's called acute. If we have only Q wave, no ST elevation, but T inversion, that's a subacute. If you have only Q wave, that's a definitive or old MI. Okay?
Okay, thank you very much.
You're welcome. Now, let's see the next one is 180, Eden. Let's
Yes.
see. Okay.
First it is rhythmic.
More or less. Okay.
Yeah.
And it's at 1, 2, 3, 4, 5. Okay, 1, 2, 3, 4, 5. So it means around
60.
60. All right. 60 beats per minute. So it's normal. All right.
And axis.
Now, let's see first the P wave. Okay, the impulse formation center. I like the axis when we are talking about the QRS. And this way we are going step by step. We start from the P wave and ending with the T wave. Okay, so the P is what kind of P we have here? Positive in lead number 2, negative in AVR, and every P followed by QRS, meaning that's a sinus rhythm. Okay, all right. Now, next one, the morphology of the P, but that's a nice round, and it fits into the 1/4 of the big square, so it's okay.
Yes.
0.1 second and 2.5 maximum, that's okay. PR interval, that's starting from the beginning of the P till the beginning of the QRS complex, is okay, normal, so there's no AV conduction abnormality. Next one, the width of the QRS, how wide the QRS is, okay? And this QRS is?
Pathological Q Wave.
This QRS is narrow. This QRS is narrow. So it's meaning there is no intraventricular conduction abnormality. Now you should search for the pathological Q wave. Now list me, where can you see pathological Q wave?
2.
Okay, for 2, for sure, yes.
AVF and
AVF and 3, okay? We do see 2, 3, AVF, okay? Do you see any ST changes in these leads? No, there is no ST elevation. So it's meaning that we do have an inferior definitive or old MI. Okay, so that's an old MI. Only the necrosis stays here. All right, this is one. Okay, let's continue. Let's move around. What can you see in lead number 1? That's a QS complex. That's pathological again. QS is Q. All right, it's very wide. Only we have Q wave. There is no R wave. Okay, so that's a QS complex, that pathological one. Let's go backward. Okay, AVL, no, there is no Q wave because we have an initial R and an S. That's okay. Go back. V6, yes, we do have a QS again at a little teeny tiny R at the end. V5, V4, again, Q wave, and V3, and V2 we have, yes?
Yes.
All the way we have this Q. Now let's see what is the segment, ST segment. It's only 1 millimeter here, all right? So it's 1 millimeter. It's not more than 1 millimeter. So it's nothing, nothing, nothing. So there is no ST elevation in these leads, but we do see a negative T wave. Yes. Similarly to a lead number 1, meaning that this is a subacute anterolateral MI. So this patient has 2 MI. An old one, and a subacute.
Oh, it is possible. Why?
Why not?
Okay.
Whoever had an MI has a higher chance to have another MI.
Okay.
Because it's meaning that the coronary is already affected, so it's narrowed down, and they could have some kind of predisposing to ischemic heart diseases. All right.
Okay.
Good. All
Sorry,
right.
could you just repeat again? It's inferior. Sorry.
Inferior, we do see that inferior, but that's an old, because we have only Q wave, no ST or T changes. Okay, that's
And
an
which
old.
one? Which one is the other one?
Another one, V2, V3, V4, V5, V6, and lead number 1. That's a anterolateral.
Oh, okay.
And we don't see ST changes, but we do see negative T wave. So this is why we said that's a subacute anterolateral MI.
Okay, thanks.
All right. Okay,
Thank
good. Let's move on. Okay. No, somebody already came. Amit, you haven't been here, yes? Or you were already presented something? Amit,
Yeah. I already did.
you already have. Okay.
Yeah.
Okay, Ankit. Ankit sign. But you haven't been here, yes? Come on. Looks like no answer. Okay. Who? I don't know. Ju Choi?
Yes, I'm here.
Okay. All right, it's your turn.
Okay. So it seems it's rhythmic.
Mm-hmm.
And then just a sec. I just wanna. Okay, so it's rhythmic, and the heart rate seems to be around 300.
Okay, how many? 1, 2, 3,
like
and less than 4. So it's around 80. It's okay, 80,
around
90.
80.
It's very difficult to see it. This is why I'm happy. Okay, go
No.
on.
Okay, and then we have P waves followed by Qrs, but
yes.
it's pointed.
Well, okay, it's pointed if it's more than 2.5, but I think it's not more than 2.5 millimeters. So that's still in the normal interval, I would say it.
Okay.
All right. So this is, if it's high, it should be around 3 or 4 millimeters. You will see it is very big one and very tall one. Okay.
Okay. So it's upright in lead 2 and inverted in AVR. So it's a sinus rhythm.
Okay, very good, very good.
And then looking at the PR interval,
Mhm.
just a sec. It seems is it 5?
Well,
Four?
no, it's not 5. It's only 4. It's 0.16, so it's okay. That's no
Okay, so it's normal. So no AV block.
no AV block. Okay.
But the QRS seems
Uh-huh.
wide.
Yes, very good. The QRS complex wide, indicating
Indicating hypertrophy, maybe?
no, indicating if you do have a sinus written or supraventricular written and a QRS wide, you
Oh,
have to think about
ventricular escape rhythm?
no.
No?
Listen to me. Don't rush. We
Okay.
do have a sinus written. So the impulse is generated by the sinus and that impulse goes down to the ventricle. If the QRS is wide, you do have a problem with the ventricle activation. Takes longer, but every impulse what came from the supraventricular area got to the ventricle. So the conduction abnormality should be inside the ventricle. So you have a bundle branch block.
Okay.
Which type, right or left? This is what you have to decide.
Okay.
Whenever you do see the wide R wave, V1 or V6, where can you see the wide R wave?
V6.
So
So
meaning,
it's a right.
no.
No?
Whenever you have the wide R, that area activated later because the impulse coming toward this area for a longer time. That means there's a left bundle branch block. If you had a wide R wave in V1, that'd be the right bundle branch block. But because you do see in V6, that's a left bundle branch block. Okay?
Okay.
Don't forget it. Whenever you do see the wide R complex, the block is there. And normally, in left bundle branch block, you do have a nudged R wave in V6 and the QS complex on the right side. If you do have a right bundle branch block, what you have a wide R complex in V1, and you do have a S wave that is a little bit widening. So you have a slurred S wave in V6. That's a right bundle branch block. Okay?
Okay.
Capish? No. So we do have a left bundle branch block. The next one you have to look at, can you see any pathological Q wave?
Just a sec, looking for it. No, I don't
Yes,
think so.
we do.
You do?
Yes, we
Okay.
do. Look at V1, V2, V3. Yes, we do. However, this is due to the left bundle branch block. Okay, this is why it's difficult to diagnose an anterior MI if we do have a left bundle branch block, because left bundle branch block itself altering the first phase of the QRS complex. Okay.
Okay.
The right bundle branch block does not influence the first part of the QRS. If you go and watch again that conduction abnormality and the videos, you will see it. Okay, please, it's important, very, very important.
Okay.
Okay, so that's a left bundle branch block. And we do have a ST depression in V5, V6 and lead number 1 AVL. That the secondary due to the left bundle branch block, because the ventricle activated abnormally, the reposition is altered. This is why it's called secondary STT changes. All right.
Okay.
Okay. Now let's see. Ankit, are you here?
Yes, doctor.
Thank you very much. Okay. Now it's your turn.
Okay. So I think it's arrhythmic. And the heart rate is 1.
You can see it's around 60 again.
Yeah,
it's okay.
60, 65.
All right.
And
okay.
wait a minute. And for the axis, for in the first plate, it's P is positive, and in the AVF, it's AVF.
Biphasic in AVF.
So I think it's normal.
Yes, normal biphasic.
Yeah.
So the axis is
It's normal. Axis is normal.
0 degrees. That's normal. Okay. Go on.
And now
Impulse.
the
P waves.
for P waves. 1, 2. I think the P waves are continuous with the QRS complex followed by QRS complex.
Yes, but not everywhere.
Yeah, well, so it's a AV block.
Mm-hmm. Which type
And,
of AV block?
Type 2, second degree.
Second degree
Yeah.
AV block. And which one?
So now we have to look at the PR interval.
The last
And-
conducted PR and compared to the first conducted PR. Are they equal?
Yes.
No.
No, wait. I have to zoom.
Zoom it.
Fair. I think the first one is bigger.
The last one is bigger than the first one.
Yeah.
That is an unconducted one. This is the last, and that's the first. Okay.
Okay.
So what does it mean?
So it's mean Mobase type.
Type?
Type 2.
No.
Um,
Mobis type 2, again, the theory, you should watch the theory and learn it. If the last one is same as the first one, that Mobis type 2. If the last one is longer than the first one,
Mobase type 1. Okay.
Okay, that's a Mobis type 1. Pathological Q waves, or width of the QRS is narrow. Pathological Q wave, there is no pathological Q wave. Okay, so that's it. However, I don't like this area.
This one.
Yeah, I don't. Now let's see.
Is it
This
hypertrophy?
No, there is no hypertrophy here.
Okay.
Look at that's a P wave.
Yeah.
That's a P wave. That's a P wave.
It's different.
The next P is coming here. Okay.
Mm-hmm.
Now, let's compare this PR because that was the last conducted PR. I would say that this is about the same than this one. Okay.
Okay.
So I believe that this P wave, what we have here, this P is not conducted. This is the same as here. However, we do have something here. How would you call this type of bit? Because that's not a conducted bit.
It's not a conducted, so
it was a gap, and later on a lower center hit, so that's an junctional escape bit. Okay, so there is a chance when the AV does not conduct that the lower center is going to fire.
Okay.
And this is why we call that's an ectopic and basically a later coming bit. Okay.
Okay. Junctional.
Junctional bit, exactly.
Yeah.
Okay. Good.
Okay. Thank you.
All right. Let's delete it. So these kind of escape bits, usually that comes later and coming from a lower center. And the lower center, junction or ventricle. But because the QRS look the same, that has to be a junctional escape bit because we have only one. Okay, let's see. Liu. Oops.
Can you hear me?
Okay. Yes, we can hear you.
Okay, thank you. So the rhythmicity is rhythmic.
Yes, it is. Looks
And
like it's rhythmic. Yes.
I can see the
1, 2, 3, 4.
So it's
Okay.
normal. It's like 75.
Okay.
And now we start from the P wave.
Yes, start with a P wave.
The P wave is, it's okay. It's fine.
Yeah, we do see P wave in front of the Qrs and positive in lead number 2, negative in AVR. All right.
So yeah,
That's
the
a
axis-
sinus. Okay, that's a sinus. Now, what
Mhm.
about the PR interval?
Well, I can see two on my screen, but
Okay,
it's P.
let's see.
Yeah, PR interval would be 2.
1, 2.
Yeah,
Okay,
it's too
1,
long.
2, 3, 4, 5. It's 0.2, so that's the limit. You can assume, and here you can see very nicely starting from the square here and start from here. So that's okay. 0.2 is fine.
Okay.
It has to be more than
More than
0.2,
0.2.
so it's not elongated. All
Mhm.
right. Next one, QRS. Is it wide?
Yes.
Okay, we do have wide QRS complex. So what does it indicate?
It means that the conduction in the ventricular, like it's in the ventricle,
Abnormal.
like through the
Okay,
ventricular
which
muscle.
one? You have to compare these two. I
Which
just
one?
explained before.
Oh
Where
yeah,
can you see the wide R wave?
it means it's at the right side.
So that's a
So it would be the right bundle block.
exactly. That's a right bundled branch block. Okay, what about the axis?
With and AVF. Okay. The axis is right deviation.
Why?
Wait.
Lead number 1 is positive.
Okay. Sorry.
AVF is negative. Lead
So it's-
number 2 is negative, meaning
Meaning, wait, let me just. It's the left, like it's left, like extreme left. Yes.
deviation. Okay, what does it indicate when we do have an extreme left deviation?
Well, because we have right bundle branch
Yes,
block.
together with the extreme left deviation, what does it mean?
Is it normal? Because like,
If you do see only an extreme left deviation, what would you diagnose? Only an extreme left deviation, nothing else, only a left extreme deviation. What would you say?
it's not good.
It's not good for sure. That's a hemiblock, left
Okay.
anterior
Oh,
hemiblock. Yes, that's a left anterior hemiblock. Okay. If you do have an extreme right deviation, that can be that's a left posterior hemiblock. And when we do have right bundle branch block plus an extreme left deviation, that is called bifascicular block because missing the right bundle and missing the anterior fascicles. Okay.
Yes.
Good.
Thank
Pathological Q wave. No, we haven't reached pathological Q wave. No. Hypertrophy. No. So that's finished right now. And again, you do see these secondary STT changes due to the abnormal conduction. Okay.
Yes.
Good. All right. Let's move on. Okay. Maximilian.
Hello.
Hi.
Okay. It looks rhythmic.
Yes.
The heart rate is.
Except here.
Oh yeah, of course, that's a big one.
Okay. So that's arrhythmic, but mostly rhythmic, but something made it arrhythmic. Immediately you can say that what kind of bit made it arrhythmic? How would you call this bit?
Ventricular escape bit.
This is vent escape. Why? Is it came later? Escape comes later. Premature comes earlier.
So it's premature.
Now that's a premature ventricular bit. It's okay. Ah, it's fine. Okay. Let's see another area. Okay.
Another. Or I continue with the normal.
Yes. Continue with the normal part. Yeah.
The heart.
Do we have P waves? Yes. Heart rate is around.
One,
Maybe
two,
I can judge it.
5.
Okay. 1, 2, 3, 4, 4.5. Okay.
Normal.
4.5. 65. Good. Normal. Okay.
Do we have a P wave?
Yes.
Yes, we do.
And the normal one. Okay. The sinus P. Yes. It looks
all-
like a normal sinus. Okay.
Looks like all P waves are followed by a QRS.
Okay. Very good.
Normal. The morphology of the P wave looks
Mhm.
normal.
PR interval.
PR interval looks normal.
Okay. QRS, is it wide?
It's wide in the abnormal one we talked about earlier, but it looks like it's a bit wide in V3 maybe.
Okay, so V3 and looks like in chest list, you can see a little widening in the first phase. Okay, something like here. Okay, and here as well, but not too nice. Okay, so what about the PR here?
PR.
There, yeah. Okay, I can
Very short?
enlarge it. Yes, that's very good. Very good. Very good. So this shortening of the PR cannot be seen anywhere. Here it looks okay in lead number 2. And in lead number 3, you don't see it. In lead number 1, well, if you get closer, I try to get closer, you will see, I magnify it, see, that right after the P, a little teeny tiny sloping upward. But here in the other leads, for example, in V1 or V2, 3, you can see nicely that this is a short PR indicating
Some sort of blockage? No.
the impulse gets faster to the ventricle.
Mm-hmm.
So
I don't know what to say. It's
how do we call when the PR is short? What kind of syndromes are those? There are 2 things that we learned. When the QRS is wide, when the QRS is narrow.
Pre-excitation.
Exactly, that's a pre-excitation. And when the QRS is wide, that's called WPW syndrome. And here you can see that in V1 it's positive. So that's A type because the bundle of Kent located on the left side. Yes? So please, the theory, don't forget about the theory. Okay?
Professor,
Pathological, yes?
right, can you say again how you knew it was type A?
Because in V1, we do see positivity. All right? This indicates the bundle located on the left side and everything coming toward the right side. If you do have a negative deflection in V1, that's a B type. That's a B type, okay? And that's a A type. That's the 2 different types, okay?
Thank you.
All right, okay.
Excuse me, doctor, what was the syndrome? WPW.
WPW, Wall
Okay,
Parkinson White syndrome, the pre-excitation syndrome. Okay, watch the theory. All right, good. Let's see who is the next one. Miu?
Yes.
Okay, your turn.
Mhm.
Oh, doggy,
So
yes.
this, sorry. Okay, so this is, hey. So this is rhythmic.
So it's rhythmic.
And so yeah, can you hear me? Sorry. Hey. So this is man.
Well, cannot you put the dog outside for a while?
Yeah, I will. Yeah, I'll put her into her house. Can you give me 1 sec? Sorry.
Yes, we are waiting.
Có vẻ.
Oh, yeah.
Sorry, she's gone.
Okay, so
Okay,
let's
so
start.
okay. So I think this is rhythmic.
Okay.
And heart rate is
Okay, this is
it's
about
about
1, 2,
3.5.
3, 3, a little bit more than 4, so it's around 90. Okay, good.
And there are P waves.
P waves, yes, and these are every P followed by QRS, and these are sinus P wave. Okay, good. Morphology of the P is fine. PR interval.
PR is normal.
Normal, very good. QRS, is it wide?
I think it's narrow enough.
It's narrow, okay, good. Axis.
So the axis is 31 is positive and AVF is negative, but D2 is positive, so it's
okay.
the left deviation.
It left deviation, okay, between 0 and -30. That's okay, good. Next, coming the pathological Q wave.
Oh, pathological Q waves. So the chest release.
V1, V2, V3, V4, and we do have
also there is ST elevation.
ST elevation, okay. In V5 we have only ST elevation, and in V6, well, it's about 1 millimeter. I don't think that is okay, but here, yes, a little bit elevated in lead number 1. So what does it indicate when we do have a Q wave and ST elevation in the V2, V3, V4, V5?
So it's some type of MI.
What kind of MI? Where is the location of the MI?
Acute.
Yes, that's an acute, but what is the location?
So it's on the anterior side.
Antero, yes, anteroceptor or anterolateral, because V5 you can see it. Yes, an acute anteroseptal MI. Yes, correct. And again, there's no sign of hypertrophy in this ECG as well. Okay, good. All right. Let's see. Yes, it's fine. Okay, let's see.
Professor,
Yes.
what are the signs of hypertrophy that you look for?
Okay, let's go for a hypertrophy. Okay, wow, it's yours.
Mine?
Vivian, it's yours.
Okay. It's rhythmic except for down here.
Except here.
Except right there. And it looks as though
So
there's...
it's not rhythmic. Okay, it's not rhythmic.
Yeah, it's not rhythmic.
Okay.
And there seems to be there's no P wave there, So
What? What?
in the section, no, in the section you circled.
P, yes, we do have P waves.
Okay, so
P is
there is a
coming
P wave,
regularly.
but
Yes,
there's
we
no
do have P,
QRS that
but
follows.
no QRS. Okay.
So
Huh?
it's an AV block.
Okay, which type?
So they look about the same, the last and the first, or actually the last looks longer than the first.
Yes, so that's longer than the first one. That's Mobitz type 1. Very good. Very good. Okay, go on.
And then to me, the QRS looks maybe a bit narrow.
A little bit narrow. Narrow. That's narrow.
Yeah, okay.
All right, next one. Axis?
Axis, so lead 1 is positive and AVF is also positive. So it's, sorry, 1 second, it's normal.
Mm-hmm.
And
lead number 3 is about equiphasic, so you are somewhere here. Okay, between lead number 1 and 2. So it's around 30.
Okay, around 30 degrees.
Okay. Go on.
I guess I would look at the ST segment next.
No, looking at the pathological Q wave.
Pathological Q Wave. Okay, it's very tall in V4, V5, V6.
Wait, pathological Q wave cannot be tall. That has to be deep.
Oh, okay.
Can you see it? Here.
In lead 3?
And
so
here as well.
It's never pathological if it's just tall?
Look, Q wave never positive. Q wave negative. And negative wave cannot be tall.
That's what I mean. Sorry.
Can be deep, but not tall.
Yes.
But this is, okay, so we do have a pathological Q wave in lead number 3 and AVF. And we do see ST elevation here as well. Yes, can you see that elevation?
Yes.
Indicating?
An acute inferior MI?
Inferior MI, very good. Okay, acute inferior MI. And we know that inferior MI very frequently comes together with posterior. So the mirror side, we do have prominent R waves, big R waves on the right side, yes, because normally the transition occurs between V3 and V4, and here V3, the R is bigger than the S wave, and you do have ST depression, so it's indicating an acute infero-posterior MI. All right?
Okay. Acute inferior posterior MI.
Okay, now the next one. Do we see any sign of the hypertrophy? Can you see tall R wave on the left side? And when you summarize the S wave in V1 or the V5 or V6, whichever is greater, the R wave, it should be bigger than 35 millimeters. And here, yes, we do see this kind of voltage criteria, and that meaning that's a left ventricle hypertrophy. And this is what you have to find it.
So is left ventricular hypertrophy the only type of hypertrophy we can diagnose on the ECG, or can we also see other types?
You can see right ventricle hypertrophy. In right ventricle hypertrophy, what you do see, basically, I change the color. You can see a tall R wave in V1 and a deep S wave in V5 or V6. So this is what we say that the RS ratio in V1 should be bigger than 1, and the RS ratio in V6 or V5 should be less than 1. So if you do see a deep S on the left side and a tall R on the right side, that can indicate a right ventricular hypertrophy.
Okay, thank you so much.
Watch the nice movie about hypertrophies
Yes.
and examples as well. All right, good. Now let's see the following one. I think I wanted to what was the, I think we discussed this one and we have not discussed this. Okay, now who is the next one? Lethal. Come on. Oh, yes, Lethal. Nordkin, Lethal. Are you here?
Yes, I'm here.
Okay, good. Now let's solve this ECG.
Okay, it looks rhythmic with a heart rate of 75.
Okay, good. Yes.
Then the axes are
okay.
We have yes, we have positive on lead number 1, then negative on AVF. It's a left deviation.
And this in lead number 2, it's about, you call acuphasic, it's fine. So minus 30. Okay. All
then
right.
we look at P waves. We have P wave in front of every QRS.
Okay, we do. Yes, go on.
And it looks normal from my
Okay.
point of view.
Yes, all right.
Then we look at the PR interval, which also looks normal from what I can see. It's not shortened or prolonged. QRS complex is narrow.
Okay. Pathological Q wave.
Yes, we have pathological Q wave in lead number 1, in lead number 2, 3, AVF, and also in V1, V2, V3, V4, and a small one in V5.
Okay. ST segment?
We don't have elevation or depression. It looks normal.
Yes, we do have in lead number 3 and in AVF because it's 1 millimeter in the chest leads. Okay. Yes,
yeah,
we
it
do.
Looks it looks a little bit elevated.
Okay. Yes. So it's meaning that we do have a.
We do have NMI, but this is
inferior.
Inferior and anterior. It's
wait. Inferior acute. Okay, STEMI. And there is no ST changes, but maybe we do have a T inversion. So we do have a anterolateral.
Yes, anterolateral old MI or subacute.
Old or subacute. Yes, that's it. And there is no sign of left ventricle or right ventricle hypertrophy. Yes, that's it. That's it. Okay, good. All right. Okay, I'm erasing these marks. Fine. Okay. I'm searching for a good one. Actually, a good. Yes. Okay. Now, who is the next one? Peter.
Yes.
Okay, your turn.
This is rhythmic. And the rate is it's around 150 beats per minute.
Yes, about 150. Okay, good. It's very close to each other. Okay.
Very high. And there is the there is
We do have
the
P
P
waves.
wave. We do have
Yes.
P wave, and they're kind of combined with the T waves.
Well,
And the-
because it's a tachycardia. This is why the P is getting closer to the T.
Yes.
Okay.
And
Go on.
the QRS complex.
PR interval.
The PR interval. The PR interval is wait a minute, 1, 2, 3. Is wide.
No. From the
Wait.
beginning of the P till the beginning of the QRS. That's okay. It's
It's okay,
over
less than
0.2, and this is not. It's less than 0.2. Okay, good. Next one, QRS. Is it wide
QRS
or
is,
not?
It's narrow.
Okay, good. All right. Axis.
What about the axis?
You have to calculate the axis. That's about. Lead number 1 is positive. AVF is equiphasic.
AVF is
so indicating the axis is 0. Normal. Yes?
Sorry, repeat that.
1 is positive. You are on the left side. AVF is equiphasic, so it's meaning the axis should be perpendicular to the AVF. AVF is 90. Minus 90 is 0. This is why it's 0. Okay.
Yeah, okay.
Next one. Next one. Next one.
This elevated ST.
No, pathological Q wave. Can you see pathological Q wave step by step?
Pathological Q wave. Yes, I can see pathological Q wave.
Where?
In lead. In lead 3.
V2, V3, V4, V5. I would say V6 as well. In lead number 1, well, I don't think so. Okay. And ST elevation as well, indicating?
Acute MI.
What is the location?
Anterolateral.
Anterolateral, and in AVL, ST elevation as well. Anterolateral acute MI. This is what we do see. Yes. Okay. Good.
Yes.
No sign of hypertrophy, nothing else. Only these things we can diagnose. Okay, good. Now that's a difficult ECG. Okay, now who? I don't know whether Sunji?
Yes.
Okay, your turn.
So it's not rhythmic.
Not at all.
No, it's arrhythmic, and the heart rate.
It's around 90, 80, 90. It's okay, good.
Okay. So it's normal, the heart rate,
yes.
And the impulse. I don't really see a P wave.
No, we don't see P wave. That's great because there is no P wave.
So no
arrhythmia, no P wave, meaning?
Is it an SA block?
No. Arrhythmia, no P wave. What did we say about that? Arrhythmia, no P wave. Atrial fibrillation.
Oh.
Don't forget, you don't need to see the fibrillatory waves. It's enough if you see nothing but only arrhythmia and no P wave. That's atrial fibrillation. Okay, move on. QRS, is it wide or narrow?
It seems wide.
Okay, wide. Okay.
And then the axis, it's positive in lead 1 and positive in AVF, so it's normal, the normal axis. And
okay, good. Pathological Q wave.
Yes, we see it in lead 3.
Okay, only in lead 3.
Yes.
And negative T wave in lead 3. Okay. You do see, okay, why the QRS is wide? What could be the reason why we do have this wide QRS, especially in V1? We do have a wide R wave and a slurred S wave on the left side. So what does it indicate?
So it's a right bundle branch block.
Very good. We do have a right bundle branch block. Okay. Now, however, if you do see a deep S in lead number 1 and only a Q in lead number 3 and the negative T wave, this is called S1 Q
Q3
3 T. S1 Q3 T. That's a syndrome, and that is called, or this is due to pulmonary embolism. Pulmonary embolism. Okay, don't forget it. This is an acute P pulmonale, or okay, this is right heart failure, acute right heart failure. Okay. About 20% of the case when the patient has embolism of the pulmonary artery, they do have a sign on ECG, and that one is S1 Q3T, because we do have an acute stretch of the right ventricle, and that causes the bundle branch, right bundle branch block, and the atrial fibrillation. Okay, good.
Okay.
All right. Oh, yeah. Okay. Now, let's see this. Okay. Who is the next one? Vivian already. Peter Wood. I think it's me who already solved an ECGS.
Yeah, I did.
Oh, you did it. Who hasn't solved the yes and the Dougie? For sure. Okay. Who has not solved any ECG? Okay, everybody. So adesso it's your turn.
Okay, first of all, it's rhythmic. It's 1, 2, 3, 4, 5.
1, 2, 3, 4. 1, 2, 3, 4. 75. 1, 2, 3, 4. 1, 2, 3, 4.
So 75 heart rate, and then we see the P waves before QRS waves.
However,
okay, but the PR distance is long.
no, the PR. The P is wide and notched. And you see that here in V1, the terminal phase of the P is deeper. Okay. What does it indicate?
I don't know.
Anybody?
Is atrial hypertrophy.
Which atrium?
Right.
No.
Then left.
Yes, whatever is left, the left one. Okay, so we do have a left atrial hypertrophy, or this is called the P mitrale. Okay, good. Now you can go and look at the PR interval, and this looks a little bit elongated, as you said. That's okay, all right, because it's starting from here and ending here. Yes, okay, go on.
Yeah. And then the QRS is, it's wide.
No, it's narrow. It's not wide. If you look at it, you will see that it's not wide. Okay.
Okay. Okay. Pathologic. Okay, the axis. So lead 1 is negative and AVF is positive.
AVR is negative, so this is around 90, 90, and 120. Okay.
Okay.
So it can be a right, extreme right deviation, but maybe only a right deviation. It's very difficult to see it. Okay. Next one.
What's next?
Pathological
Q wave. So V2, V3.
You do have initial R.
Oh, R spike.
So because you do have initial R, this is called S wave. What you have a very deep S wave. Okay, very deep S wave. And if you summarize the S wave with an R wave, it can be a left ventricular hypertrophy as well.
Okay.
Okay.
Can you repeat that again?
Which one?
How you knew it was the left ventricular hypertrophy?
Because on the right side, we do have a very deep S wave. And the left side, we do have a tall R wave. This is how we know it. And if you summarize that the voltage criteria, it should be bigger than 35 millimeters. But the ECG is not the best one to diagnose hypertrophy. It only gives a clue that could be a hypertrophy.
Okay.
Okay, good. All right. Oops, it's still left something here. Okay. Yes. All right. Now let's see. Amit.
Yeah. Okay. First thing, okay, if you want it by order, we can do it, but I think it's hyperkalemia.
Again, the last time you didn't like teasing anybody. So in an ECG, you have to have some teasing
Sure. So
when
let's
you
do
see the diagnosis. You are right, but
so
nobody will understand why. Okay, so
rhythmic,
please. Okay,
rhythmic rate about, let's see, 75, 60.
Okay, good.
Axis towards 90 degrees.
Okay, good.
P wave, we have the P wave morphology looks normal, but we have a
little bit
prolonged
flat.
PR.
Little bit flat. This P is little bit flat. Okay.
Yeah, okay.
All right. That's a part of the diagnosis as well, because flattening of the P, elongation of the P.
I meant like the positive in 1, 2, 3. Okay, but okay.
Good. Good. Go on.
Okay, PR looks every P. After every P, we have QRS. PR looks elongated, and now Q wave. Right? So Q wave, I don't see any Q wave.
No.
Okay, ST. QRS. Sorry, QRS is wide and really wide. Really wide.
It's wide. Okay.
Yes. The morphology may resemble LBBB, but we know it's not there.
No, it's not an LBBB because if you look at that's a R I mean, there's a R propagation. It's okay because between V3 and V4 we do have the transition, so it's fine. It doesn't mean that doesn't indicate the left bundle branch block. It's okay. That's fine.
We can also exclude it because it's really wide, more than the usual. Okay.
Okay.
And really high, tall, peaked T wave, really wide QRS. Yeah. So
this is
hyperkalemia.
exactly, yes, this is why you have diagnosed hyperkalemia. Sometimes the hyperkalemia can be so severe one that relatively there is no P wave at all, and the QRS as a T wave looks the same, looks like the same. And whatever the ECG gives the diagnosis that the rate is about double. However, this QRS complex, that's a T wave. That's a QRS complex, that's a T wave. So sometimes this be similar to the T and the QRS complex because the QRS is elongating. Okay, good, very good. All right, let's move on. Yeah, we already had this. Yes. Okay, let's have this one. Okay, Ankit. Sleeping again. Aiden.
Yes.
Okay, please.
So it's rhythmic.
This is rhythmic. I don't think so. This is not rhythmic. Okay.
Okay, because of the V1 or
because of the rhythm strip. This is what you have to consider rhythm strip. But you can look at other leads. Again, that distance is not the same than this distance or that distance. But only a short. We have only 3 bits or 4 bits, sorry. So this is the longest strip. And you want to see the rhythmicity, you always should consider the longest rhythm strip, okay?
Okay.
Now, so this is arrhythmic, okay? The rate is around, let's see, 90, okay?
Okay.
P wave, let's see, P wave. Can you see P wave?
No.
Okay, so?
Atrial fibrillation.
Very good. Oh, don't hesitate. Say it immediately. It doesn't hurt too much. For you, especially.
Okay.
All right, so that's an atrial fibrillation. All right, now let's see the morphology of the QRS. Is it wide or not?
In the V1, V2, V3?
Yeah, all the way is wide because it's starting from here and ending here. Yes, it's wide, but in V1 and V2, we do have a wide R, yes?
Yes.
Okay. What does it indicate?
Bundle branch block.
Which one?
Right.
Yes. Don't ask, say it. Right bundle branch block. Okay.
Yes.
Okay. Axis.
Axis, one is positive and AVF is also positive.
So?
Is it okay first?
So no more.
No more, yeah. So
That's it,
AVF
no
is
more.
positive, right?
Yes, right.
Yeah.
Both positive, so this is why we said normal. The axis is normal, okay?
So there is not hemi block?
No, nothing at all.
Okay, so it just right bundle branch block?
Just atrial fibrillation and right bundle branch block. Just it.
Okay.
That should be enough. There's no pathological Q wave, no hypertrophy. That's it. Nothing else. Nothing else. Okay. All right. Let's see.
Sir?
Yes.
Do we have some time to discuss the midterm next week?
Okay, let's see. The next week we meet in the lab. Okay, hopefully I will recover from this virus, nice virus, and I can spread the virus to you as well. Okay, now, so the next week we are going to practice, and whoever can take the midterm will take the midterm. Okay, I will give only good marks to those who can take the midterm the next week, and others who need practicing a little bit more, we can do the midterm later. All right, it sounds good.
It sounds good, but it will be oral and we just have one tracing.
Yes, you have only one tracing, and that's the oral.
Okay, and what if we decide to do the midterm but we get it wrong?
That you won't get any mark.
But then we can do it again?
Exactly.
Okay, thank you.
You can do the midterm as long as you feel that you are confident with the ECG. All right.
All right, thank you so much.
You're welcome, but don't go away. Solve this ECG. That'd be the last one.
Okay.
See, this is why it's good to speak up for everybody, because nobody who is going to present everything immediately. Okay.
So
Not.
it looks rhythmic to me, looking at the bottom.
That's rhythmic. That's rhythmic. Okay.
And so then the heart rate, I can't really see the
1, 2, 3, 4, 5, 6, a little bit more than 6, so it's less than 50, so it's around 45. Yes. So it's bradycardic. All right.
And then we look at P wave. In lead 2, it's positive, and AVR, it's negative. So it's sinus wave. And then are all the P's followed by a QRS?
Are you sure?
No, I'm asking myself.
Are you? Yes, asking. I see. So louder, you are asking yourself. Okay. So you are very confident with your knowledge. Yes, of course, I be very good with myself, so it's no problem about it. Okay, so.
Yes, I believe all the P's that I see are 1, 2.
Yeah, but I do see more P that you see.
Oh.
This is one P. That's another P. That's another P. Yeah, a lot of P's, and not every P followed by QRS. Only every second one is followed by QRS. So.
Right. So then it's a block. It's an AV block, and it's
Yes.
And
every second P conducted.
So it's a high degree AV block.
No.
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 2 to 1 block.
2 to 1. Yes. 2 to 1 AV block. Yes. Okay. Go on.
So
QRS is narrow or wide?
QRS looks wide in AVL in V1.
No, it's not wide. That's not wide. This is not wide. It's narrow. Everywhere is narrow. The wide, when you talk about wide QRS, it has to be wide. Okay.
Okay.
For example, if you no, I cannot go back that. Now I can go back. See, that's wide. That's not wide.
Okay. Thank you. It's not wide.
You're welcome.
So then the ST segment.
No, pathological Q wave.
Okay. If there's a pathological Q in 3 and AVF.
2, 3
then
AVF.
It's inferior, and then
ST elevation as well.
So it's acute. It's acute inferior MI.
Yes, and when you do have an acute, but anytime you should look at the chest leads, and you do see, well, not too many. It's only, here in V2, V3, you do have ST depression, but you don't have any prominent R wave. So you can suspicious about the posterior MI as well. So because usually inferior posterior comes together, so inferior posterior, but really we don't see the nice tall R wave what you should see in, let's see, as a sign of mirror image of a Q wave on the back.
So you would see it in V2, V3.
On the anterior lead.
Okay.
V2, V3, up to V4. Yes, yes. So this is what we say, the 2-to-1 AV block and an acute inferior or inferior posterior STEMI. That's it.
But you would not say posterior because you said you can't really see that.
Well, okay, but if you do see this ST depression, you can mention it. You won't cause any problem. Okay. If you are not recognizing something, that could be problem. If you recognize more, that's not a problem.
Okay.
All right. Maximum,
All right.
they will say that, okay, that's too much. No, it's not too big problem. Okay, it's not pathological. Okay, fine. But you said something. They won't count as an error. Believe me.